Good morning, everybody. My name is Ana Velez. I am an associate professor for the University of South Florida, and today I will be talking about COVID-19 and Spanish flu, the two worst pandemic of the century. This slide here illustrates two paintings made by myself. The one on your right represents influenza virus, and the one on your left represents COVID-19. So a little bit about history. The Spanish flu, H1N1, from 1918, was caused by, again, influenza virus type H1N1. The genes were discovered to come from avian origin. Mammals were intermediate hosts, so those genes jumped to mammals and from mammals to humans. There is no universal consensus regarding where the virus, what was the location where it was originated. So the Spanish name has nothing to do with the origin. It spread worldwide during 1918 through 1919. 15 million, or 1/3 of the world population at the time, became infected. There were 50 million deaths worldwide. Interestingly enough, the Spanish flu had 3 waves. The first wave started in spring 1918. It happens during the 1918 World War I, where thousands of soldiers, US soldiers, traveled across the Atlantic, deployed for war. This mass troop movement contributed to the global spread of the flu. The first few cases seen in United States were in March, with more than 100 cases reported at camp. And this picture here in the middle illustrates a picture in Fort Riley, Kansas, and that camp. It's very interesting to notice that more people died during the 1918 pandemic than the total number of military and civilian deaths that resulted from the war. The second wave started in the fall of 1918. Here on your right, you see a picture that illustrates the 3 waves. The first one started in March. The second one, so March and spring, and the second one was in the fall, which was the worst peak. The second peak was the worst and the more fatal, and it was responsible for most of the United States deaths. Then the third wave started at the end of 1918 and finished in the summer. Unfortunately, during 1918, many health professionals served in the US military during the war, resulting in shortage of medical personnel around United States. The economy suffered a big deal as business and factories were forced to close due to sickness among workers. The third wave started in the winter of 1918 and went all the way to spring of 1919, and this added to the pandemic death toll. The third wave of the pandemic subsided during the summer of 1919. An estimated of, again, 1/3 of the world population was infected during this time of during the pandemic, resulting in at least 50 million deaths worldwide, as we had previously said. The picture in the middle illustrates an American Red Cross ambulance transporting some of the patients. That was in October 1918. So because of the severity of this pandemic, many researchers came with different questions in order to understand and prevent further pandemics or impacts from pandemics. So some of the questions were, where it originated from? What can the public health community learn from the 1918 virus to better prepare for and defend against future pandemics? So a famous researcher whose name was Johan Halton was very interested in isolating the virus and tried to replicate the gene to see if there was something that we could learn and do for the future. So he learned that there was a small town in Alaska that had 80 natives at the time. 72 of them died, and because of that, there was a site of mass grave in that place, and that picture, the picture in the middle, illustrates that. So he decided to go there and excavate and try to find some lung tissues to see if he could isolate the virus. And the picture on the left, you see Johan Halton with his colleagues trying to excavate some bodies. And then on the right, you see Johan Halton working in his lab in 1951. Interestingly, you see how he was using his mouth to draw virus into a pipe, which is not a very safe practice today. Thank God he couldn't isolate the virus, otherwise he probably would be infected at that time. So he was very disappointed that he couldn't isolate the virus, but eventually he learned that a group of researchers led by Totenberg isolated the RNA of the RNA virus of the 1918 Spanish flu from a lung tissue obtained from a 21-year-old male that used to serve in the United States service. He died in a camp in a small hospital, and then his lung tissue was collected and preserved at that time for a later study. So when Halton learned that, he contacted Totenberg asking if he would be interested. If he could go back to that small town in Alaska and obtain some more lung tissue from those patients. Because of the weather, some of those, the lung tissues were in pretty good state. So he was able to bring this tissue to Totenberg, and then they were successfully able to isolate the whole gene of the 1918 Spanish flu. So eventually they published this paper, and it was entitled Origin and Evolution of the 1918 Spanish Influenza Virus Hemagglutinin Gene. And that was in 1999. And Halton was, of course, acknowledged as a co-author because of his effort trying to isolate the virus from these tissues from Alaska. Of course, the paper was also say that the hemagglutinin gene of the influenza virus determined the properties of the virus hemagglutinin surface proteins. These hemagglutinin surface proteins allow an influenza virus to enter and infect a healthy respiratory tract cell. They also are targeted by antibodies produced by the immune system to fight infection, and therefore modern flu vaccine work by targeting this unique hemagglutinin that is produced by different strains of the influenza virus. A follow-up paper published in June 2000 entire characterization of 1918 Spanish influenza virus neuraminidase gene describes the sequence of this 1918 virus neuraminidase gene. And of course, we know that the neuraminidase proteins are responsible to spread the influenza infection, and that fact was also mentioned in this paper, specifically describing the neuraminidase gene of the 1918 Spanish influenza virus. And this is a nice picture that I obtained from the CDC, illustrating the Spanish flu H1N1. So we know that the influenza in general and the Spanish flu is a respiratory virus. It is transmitted by droplets. The rate of transmission, meaning that if somebody is infected, there is a rate of 1.8 to 2.2 secondary infections from that case. And we're going to talk about COVID-19 in a few minutes and compare those two. The mortality of the Spanish flu was 2.5, and unfortunately, it lowered the life expectancy in United States by more than 12 years. Unfortunately, too, the mortality was worse in the healthy 20 to 40 years old, which was a huge impact for the population at that time. And this was also a unique feature of this pandemic. Older than 60 years old could also be affected, were also affected. And what happens is it is believed that patients who were older than 60 were already exposed to similar strains of influenza around 1890s, and that probably gave them some protection. As far as the healthy patients, they had a more vigorous immune response that accounted for some cases of ARDS and respiratory compromise. Unfortunately, at that time, as we say, there was shortage of nurses and doctors. There was shortage of tools. There were no vaccines, no antibiotics, no mechanical ventilators. The treatment was mainly supported and based on infection control practices. Now, why the Spanish flu spread worldwide? Well, the world was at war. Large numbers of troops were traveling, aiding to the spread. People lived close to each other in crowded conditions, some of them pretty bad. People did not value the hygiene so much. Malnutrition was also more common. And the Spanish flu, interestingly, came in 3 waves, and the second one was more deadly. Abruptly, after the third one, the virus just disappeared. And again, we already explained that the mortality was 2.5. Now, let's talk about COVID-19 and the similarities and the difference with the Spanish flu. The origins of COVID-19 also are from animals. It is believed that bats, specifically the chrysanthemum species, may be the natural host of COVID-19. And then it is also believed that this animal called pangolin, which is a scaly anteater, could be the intermediate host. This animal is used in China for traditional Chinese medicine. It was originated, of course, as we know, in Wuhan, China. It is not certain how the virus was introduced to humans, and there is a lot of controversy going on around that. Of course, it was identified at the end of 2019, as we know, and it's still ongoing. So far, more than 4 million cases worldwide have been identified so far, with more than 200,000 deaths worldwide. So why bats? Why this COVID-19 has its origins in bats as well as some other coronavirus? Well, there are more than 1,200 species of bats. Bats hold a wide variety of viruses. They live in a huge population, often very crowded, and they share many viruses, allowing those viruses to mutate. And often intermediary host animals serve as a bridge to humans. As far as COVID-19, why it spread? Globalization and traveling accounted for rapid spread as opposed to war for the Spanish flu. But for COVID-19, also crowded cities and countries have been more affected. Malnutrition, as opposed to Spanish flu, does not appear to play a major role in complications, but old age and comorbidities. This is a particular difference in this virus as opposed to Spanish flu. This one, as we know, affects more older patients with comorbidities. Asymptomatic carriers for COVID-19 usually live a normal life. They often don't know that they are infected. They may spread the disease without being aware. Also, the incubation period for COVID-19 is longer than the one for the Spanish flu. When the patients, when the 1918 patients who had the Spanish flu got sick or infected, they usually had symptoms, so they had more tendency to stay home unless it was very mild disease. So that somewhat limit the spread compared to COVID-19. Again, mortality for COVID-19 is higher in older patients. As far as shortage of medical personnel, that is controversial. We know that in 1918 there was for sure shortage of medical personnel. Now it depends on the area. And also remember that now we have a big community of patients with chronic diseases that they're living longer. And then we're adding a pandemic caused by this virus. So how are we going to do in the future? We're trying to prepare as much as we can, but again, it's a controversial point here. The same thing for shortage of medical tools. COVID-19 is also a respiratory virus. Transmission is thought to occur from respiratory droplets, just like influenza. The virus has been found in blood, stool, and ocular secretions, but the rule in transmission is very controversial. The rate of transmission is 2 to 3. So one infected person can have 2 to 3 secondary infections. The mortality, according to the World Health Organization, is 3.4, but that depending on the population, the age population that you're looking at. And now, with all the measurements that we have done, we have flattened the curve, but for how long? That is a question that still remains. And what will happen next? We don't know, as we learn every day from this virus. This is what's happening according to Johns Hopkins with COVID-19 as of May 10. So many countries are doing a pretty good job decreasing the cases, but we don't know what's going to happen next as more places are opening the economy and etc. Are we going to have a second wave, a third wave? We don't know. Now, if we compare today versus 1918, we have made considerable changes. We have improved health technology, disease surveillance, medical care, medicines, antibiotics, other drugs. We have improved hygiene. We still have ways to go, especially in some remote areas where they don't even have raining water. But we have also improved infection control practices, isolation, social distancing, They didn't have, barely had that in 1918. We are working really hard in vaccines, specifically for this virus and for other viruses. We have better pandemic planning from lessons that we learned from previous pandemics. They didn't have that much of experience in 1918. So, conclusions. Lessons from previous pandemics continue to be important. Recording lessons from COVID-19 pandemic for generations to come should take place. Behavioral changes still need to occur. We need to take care of our environment. We need to learn how to handle animals better and also in more hygienic way. We need to still have to improve hygiene, especially in remote areas, because those remote areas can have a global impact. We need to improve our diet. Ideally, less hormones, less preservatives. We need to improve our behavior because our individual behavior may have an impact somewhere worldwide. A strict infection control in research labs, especially when they're researching specific viruses, and hospitals and other places where large community gather is important. Active surveillance in circulating virus in animals with potential spread to humans, just like we do with influenza, need to take place. There are still many virologists that are trying to search these viruses that can potentially jump from one species to another one, endangering our population. We need to declare potential infection threats as soon as we are aware. And we also need to do a better job preventing chronic diseases such as diabetes and obesity and others that can cause complications from infections. And we need to continue our efforts to develop vaccines, but also accept vaccines that we already have, because we do not need the re-emerging of other virus on top of possible pandemic virus coming. And that's all I had to say for today. And this is, again, my painting. And I'm not sure if anybody has a question.